Okay, it's noon. I think we can get started. So hi, everyone. I'm Zena, Program Supervisor with the Center for Cognitive Neurology. Thank you, everyone, for joining. Just a couple of housekeeping items before we begin. You'll be muted until after the presentation, but you'll have opportunities to ask questions following the presentation by using the hand raise icon button, or you can type questions into the chat. We have Dr. Alzheimer'sDisease here. He's a physician scientist with a focus on the mechanisms, biomarkers, and therapeutics related to early Alzheimer's disease. Dr. Mercerker received both his MD and PhD from Yale University and completed his residency and fellowship at Columbia. At NYU, Dr. Mercerker wears many hats. He's an assistant professor of neurology and physiology, an attending neurologist at the Pearl Barlow Center, an investigator at the Neuroscience Institute, and the clinical core leader at NYU's Alzheimer's Disease Research Center. Take it away.
Well, thanks very much for that kind introduction, Zena. And I'm very excited to talk to you all about amyloid, fact versus fiction. Amyloid is a term that is used a lot when talking about Alzheimer's disease. It's often mentioned in the news. I get a lot of questions about amyloid from patients and research participants. And so I thought this was a good opportunity to go over some misconceptions about amyloid and to present some of the facts versus some of the fictions that may be out there or may be as a result of misinterpretation. So one question that I get, or one statement that I hear sometimes is, well, if I have amyloid in my brain, then I have Alzheimer's disease, or amyloid in the brain is something not good. Okay. And by the way, I don't have that many slides for this talk because I thought it would be good to have plenty of time to discuss and answer questions and so on and so forth. So is this true or not? Well, it's partially true. It's partial fact and it's partial fiction. So I would say the key thing about amyloid is that it's necessary but not sufficient to define Alzheimer's disease. So Alzheimer's disease has been traditionally defined by what we see under the microscope when we look at the brain. It's an autopsy-based diagnosis. That is the gold standard. And everything that we try to do at the bedside and through imaging and through analysis of biofluids is trying to get closer and closer and closer to that gold standard. And it's defined on analysis of brain tissue by the presence of two abnormal proteins. Amyloid's one of them, but tau is the other one, and tau has to be there. So what are they? Well, if you look under the microscope at a brain that has Alzheimer's disease, the amyloid, when revealed by specific stains, looks like what's indicated by the yellow arrows. It's outside of the brain cell. It's sort of in the general tissue. It looks fluffy. And this is the amyloid plaque. So if you see those, you think the person has amyloid. Then the tau is indicated by a stain that reveals a pathology in an abnormal protein inside the neuron, which is indicated by this kind of triangular shape here. And so tau pathology is the second critical component of Alzheimer's disease, and it's inside. So there's one pathology outside and one pathology inside. And even the tau of Alzheimer's disease is a very specific kind of tau pathology. The other thing to bear in mind is that about this necessary but not sufficient is that amyloid is necessary in that it precedes the development of the other pathologies, but it's not sufficient in that it requires all the additional steps. And so this graph sort of summarizes our current thinking of the evolution of the different steps biologically in Alzheimer's disease. So this is a series of curves where the x-axis is progression from normal to pre-dementia or monocognitive impairment and dementia, and the vertical axis is how abnormal that marker is or that sign is. So you can see here that the very first curve to the left is amyloid. And amyloid begins when we're normal. It begins to rise, as we know now, through advanced in imaging techniques in our 50s, potentially. So it starts to increase, and it keeps increasing as we get older. And in some people, this amyloid then leads to the appearance of tau pathology, which happens a little bit later, maybe when we're in our 60s, and it continues to rise. Somehow, the presence of these two things, or these two things, cause degeneration of the brain structure. That's this green curve, meaning that we start to see some brain shrinkage on MRI, for example. Then we start to see symptoms, memory symptoms, or other cognitive symptoms. And then finally, there's a loss of cognitive function, right? So at the mild cognitive impairment stage, the rise in amyloid has probably reached its peak already. Tau is kind of at its the biggest inflection point. Brain structure starts to get compromised, and there's a little bit of memory impairment, but it's got ways to go. And there's really minimal functional impairment. And then once someone is at the dementia phase, all of everything is sort of reaching its peak. So amyloid is necessary in that we think that it kickstarts the rest of these curves, but these curves don't necessarily have to appear in everybody, or they don't have the same shape in everybody. One example of this is that amyloid seems to non-specifically increase in the brain with age to some degree. And so when we look at the brains, or we look at the clinical pathologic correlations, as we call it, relationship of symptoms in life versus the pathology we see in the brain, in the oldest old, those persons who are more than 90 years old, the presence of amyloid doesn't seem to really divide up persons who have dementia and those who do not. And this is indicated by the two columns labeled by the red star here. So you can see that 64% of demented 90-plus-year-olds have frequent plaques. They're called neuritic plaques. These are the hallmark plaques of Alzheimer's disease. But 51% of above 90 individuals who didn't have any dementia had amyloid plaques. So the importance of the presence of plaque in terms of eliciting impairment seems to decline in persons above the age of 90. So the notion that amyloid definitely causes dementia is not exactly true, and it depends on age. And certainly there are other pathologies in the brains of these individuals that do cause impairment, we believe, and that's the focus of research. And that's another discussion. I won't get into that right now unless you have a question. Another thought that's there, I mean, even among scientists, is that amyloid is this monolithic specific protein that is toxic to the brain, right? Given that so much effort is put into it. This is not true. It's not entirely true. This is a gross oversimplification. Amyloid, if you look at its bare bones definition, it's really a histologic definition. It's a definition that pathologists made based on how something looks when they add a bunch of stains to the brain tissue, or if they look under, say, high resolution microscopy, like electron microscopy, to look at the three-dimensional structure of a protein. So amyloid proteins are basically proteins that have the ability to form these sheets, as shown in the middle here. Maybe they're composed of these individual filaments, but they're able to form these very complicated beta-pleated sheets. And that three-dimensional conformation allows them to be stained by specific dyes, for example, the Congo red stain. That's all. It's really about how something looks and whether it reacts to a stain. And so this doesn't indicate that amyloid has to be related to a specific gene or a specific protein, or as long as it fits these categories, it's called an amyloid. So amyloid as a family is very, very diverse. And in fact, amyloid proteins can affect various organs in different diseases. Some of you may have heard about amyloidosis in the heart. And so there are diseases that are related to a very different gene called transthyretin that causes accumulation of an albumin-based protein that forms amyloid, and it tends to accumulate in the heart. There are other amyloidoses that relate to immune proteins, like the light chain Ig, which is related to antibodies. Some are related to acute phase reactants, inflammatory related proteins. And these can impact many organs, okay, not all over the body. There's one that's specific to diabetes, where you have this amylin protein that forms an amyloid type protein in the pancreas. And then, of course, the Alzheimer's one, which is brain specific, and that's the beta amyloid protein. So I've had a few patients who have had amyloid in other organs of the body, like their heart. And then they ask me, well, am I predisposed to Alzheimer's disease because of this? And the answer is no, because it's a completely different protein. It's not related. And there's no way for really that protein to get to the brain anyways. So when we're talking about Alzheimer's disease and the amyloid related to that, it's a very specific biochemical pathway, a very specific set of proteins that's related to a specific process. And that's sort of illustrated here. There's basically an inappropriate cleavage of this protein called APP, amyloid precursor protein. The APP protein appears to have some vital function. We do need it. It may be needed for learning and memory, for all we know. But we do know that when we remove it from mice, for example, the mice don't do well. So APP in its normal state is needed. And normally it's cleaved properly by this enzyme called alpha secretase, and it does its normal function. For some reason, with aging or with pathologic aging, it's instead cleaved by the beta secretase, and then it leads to a series of events that form these A beta peptides that are vulnerable to aggregate together and form these complicated sheets and cause or relate to damage. And so this pathway, which is happening in individual cells right at the cell membrane of brain cells, is very specific to Alzheimer's disease, and it's not happening in the other organs. The other thing that we found from decades of research is that there are many types of amyloid even in Alzheimer's disease, and they all have varying toxicity. One way to group them, or to divide them actually, is how they look structurally, how aggregated they are. Now, I showed you the one to the extreme right, that's the amyloid plaque, that's the classic version, but you can also get the individual amyloid fibers that are fibrillar. They have this sort of fiber-like appearance to them, but they're not clumped up in a plaque. And then there are the oligomers, so it's the individual amyloid peptides that are just separated. They're not fibrous in any way. And then there's the monomer, which they're not clumped together at all, or you don't even have any sort of sheets or associations between multiple peptides. They're just individual fragments by themselves, and those are called monomers. And some of these forms are soluble in water. So the oligomers and the monomers. And so they're invisible. We don't actually see them on staining. And then there are the insoluble ones. Those are the ones that are classically known. That's the one that Dr. Alzheimer, over 100 years ago, described. Those are the fibrils and the amyloid plaques. And even within this, there are many, many, many types because it depends on how long the chains are. So you can name amyloid species also by the number of amino acids that make up the amyloid fiber. Sometimes the most common one is 40. It's 40 amino acids long. That tends to be a relatively not normal, but sort of a non-specific age-related length of amyloid. And then there's the A beta 42. And, that's the one that's particularly common in Alzheimer's disease. It appears to be particularly toxic. But there are other ones that have been discovered that have varying degrees of toxicity. Sometimes these amyloids are modified by other processes in the cell, and they have other chemical groups attached to them, and they lead to different kinds of damage. So it's a very complicated field, and people devote their entire careers to one or two of these forms. The other thing that we've found is that amyloid is not just in the brain when we're talking about Alzheimer's disease. It can be in not just the brain tissue, but also the blood vessel walls. And this is called amyloid angiopathy. So here's an MRI of someone who has amyloid angiopathy in the above picture. And in the middle section is an MRI sequence that looks for bleeding. And wherever you see a black dot, it's a small micro bleed, okay? And we think that amyloid is in the vessel wall and it caused some leakiness and blood sort of oozes out. Not everybody has this. I would say a small percent of Alzheimer's patients have this. A lot of times it's completely asymptomatic. We just find it on imaging, and you can also see it on pathology. So on the bottom, the top right picture is a stain for the amyloid plaque, showing that it's in the tissue. And in the bottom, the same stain is shown in the blood vessel wall. And you can see that it sort of outlines the periphery of the blood vessel wall. So amyloid angiopathy is an important feature of the disease. And it really has implications, for example, when we're talking about some of these new therapies that are being tried in trials. Because, for example, some of these anti-amyloid therapies, the antibody-related ones, some of the side effects that relate to hemorrhage may be related to the presence of amyloid angiopathy, meaning people who have this may be more predisposed to the side effects. The next topic is a big one. The failure of amyloid trials tells us that the amyloid hypothesis is wrong. And this is even amongst us researchers, we talk about this a lot. And I think that this is fiction as well. I wanted to give a brief summary of the trials in our field. And just going off the cuff from the slide content in particular, the initial trials or the initial studies of Alzheimer's disease didn't even focus on amyloid or tau. They focused on the cholinergic pathway because it was thought that if you have low levels of the neurotransmitter acetylcholine, your memory will be poor, and that causes Alzheimer's disease. And there's a particular part of the brain, the forebrain, that releases this chemical, and people noticed that was atrophied or shrunken down on autopsies of these patients. And so giving back or increasing the amount of that neurotransmitter would be helpful. Eventually that did lead to the medication donepezil. That's what it's based upon. But then we realized, this was probably in the 70s, a lot of the science was done. But then by the time, once the trials were going on, we realized, well, it helps with symptoms, but it's not really a disease-modifying drug. People still get worse because it's a neurodegenerative disease. And that chemical pathway is only a kind of a part of the disease. It's a byproduct of the disease, but it's not the disease itself. And so somewhere in the 90s, there was a shift to really focus more on the key entities of Alzheimer's disease, really starting with amyloid and using methods to remove amyloid, to reduce its presence, classically using antibodies. And so the initial trials that were done, one issue with them is they recruited many patients who probably didn't have Alzheimer's disease. Our ability to diagnose accurately has greatly improved over the last 15 to 20 years. So some of the reasons why those initial trials failed was that we probably had people with vascular dementia or forms of Parkinson's dementia in the trials, or even frontotemporal dementia. And we just didn't know any better because our ability to really get an accurate diagnosis was limited based on technology. The second thing that we do better now is that we were focused on stages that were too late. If you recall the series of curves that I showed you, by the late stages, all of those biomarker curves have reached their peak. Amyloid has kind of done its thing. So impacting amyloid at a late stage, or even tau for that matter, probably wouldn't have much of an effect. And so recently, I would say in the past 10 years, there's been a shift. We now recruit patients based on evidence of amyloid and tau, because now we can assess for those entities in living patients via a variety of methods. One method is to do PET imaging. So there are specific tracers that stick to amyloid, specific forms of amyloid, and tau in the brain. And so we can set thresholds of what's positive and what's not. We can also do lumbar punctures, or also known as spinal taps, and analyze the spinal fluid for the presence of amyloid and tau and neurodegeneration to more accurately diagnose Alzheimer's disease. And also, we're working on blood tests for Alzheimer's disease, and those are getting better and better. And I think in the next several years, that will be more commonly used to recruit patients. And then lastly, recent trials from prior lessons have focused more on pre-dementia stages. Mild cognitive impairment, which is that stage right before dementia. So it's where people are still quite independent. They may take a memory test and have impairment, but they're functionally quite good still. And also this preclinical stage. So preclinical means that you're absolutely normal with your thinking, your memory, your function, but you have some sort of biological sign of risk. Maybe you have some amyloid, some tau, maybe you have a genetic risk factor, but you're still normal, and it's not clear that you will necessarily get worse. But trials have focused on these more at-risk groups to intervene upon those curves at earlier stages. And so these two improvements have greatly improved the quality of the trials and our ability to interpret, for example, if the drugs are working. Okay, because a lot of our drugs are about clearing out amyloid or tau, and we can now really assure ourselves that the drug is working the way it should by using serial PET imaging or lumbar punctures to prove the point. And the other thing to realize is when we're talking about failure of trials is that the anti-amyloid trials specifically are targeting the different types of amyloid. This is a very nice cartoon showing how amyloid plaque is developed, sort of summarizing a couple of slides that I showed you before. Basically, right, so you have the APP protein that's inappropriately cleaved into A beta, and it forms these either monomers that then become oligomers, They become fibers, protofibrils, A beta fibrils, and then they aggregate further into amyloid plaque. That's probably the most mature form. Some of these are soluble, some of these are insoluble. And so this review article has nicely indicated where along the pathway these different trials have tried to intervene. So for example, there were trials several years ago that looked at the enzymes that inappropriately cleave APP into amyloid and tried to block them. And I think we found that, well, we kind of need those enzymes to do something. It seems like blocking them isn't a great idea. That we have the antibody trials, like the aducanumab trial, the crenezumab trial, which have either been controversial with a mild effect or a failure in terms of crenezumab. They've looked at the oligomers. The recent trial, lecanemab, that was in the news, is looking at protofibrils. And crenezumab actually was looking at both fibrils and oligomers. Crenezumab was a trial that was done on people who had a very strong genetic form of Alzheimer's disease. It was done in a community in a village in Colombia, country of Colombia, where there are a lot of families that have Alzheimer's disease very early on in their 40s. And so they were trying to treat people before they even became MCI. They were treating them before anything started, trying to reduce both the oligomers at the oligomer level as well as the fiber level. And it didn't work for maybe a couple of reasons, but maybe beyond the discussion here. But it's important to note that there's even more forms than this. And some of the trials that we do at our center are looking at these other forms as well. And so just to summarize this argument with the trials, well, in the past, anti-amyloid trials failed due to the recruitment of patients in advanced stages and really without what we call biomarker confirmation of Alzheimer's disease. The recent trials, so my interpretation is that the recent trials that have had these controversial, minimal, or negative results cast some doubt that the reduction of specific amyloid species in biomarker confirmed early Alzheimer's disease is sufficient to reduce decline. Okay, so it may still be necessary, but it may not be sufficient to completely stop the progression of Alzheimer's. However, I remain hopeful that adequate reduction of certain amyloid species may be necessary, in that it could be a component of a multi-pronged therapeutic strategy. I mean, we know in other diseases that are chronic, whether it's heart disease or diabetes, we need many medications. We need to look at these diseases through multiple pathways, and each of these pathways have different medications, and everyone therefore can be treated individually. And we may need to develop more sophisticated tools to track how individuals are responding to various combinations of these medications, right? I mean, for example, someone with heart disease may be on various kinds of cholesterol lowering agents or blood pressure medications, and cardiologists will use several methodologies to track how well the patient is doing to adjust those medications or add aspirin or what have you, right? There's EKGs, there's stress tests, there's imaging of calcium, of vessels, how clogged they are, lipid levels. I hope that we can get to that level, in the coming years. And so that's why we focus in parallel on detection and tracking methods as well as treatment methods, so that we're not relying just on one hypothesis to treat the disease, but we have to realize that that can't be the one and only hypothesis that leads to improvement in our patients. So related to this, there's been some news about allegations of scientific fraud that would invalidate the amyloid hypothesis. And I found this to be very interesting. And I don't. This is a bit of a sensationalist story. If you Google this, you'll find several headlines. The Guardian, critical elements of leading Alzheimer's study, possibly fraudulent. The highly influential paper published in 2006 has helped guide billions of dollars in US federal research into the disease. NBC News, allegations of fabricated research undermine key Alzheimer's theory. And this all stemmed from this Science article where a particular person sort of wanted to, was a whistleblower, so to speak, on the Science. So Sue, you have a question? I'm happy to answer it. I don't know if Zena, if you can unmute. Yeah, Sue, I can. It looks like she's.
Yeah, she has to take herself off.
Oh, I see. So if you.
She can talk. If you want to take yourself off.
Oh yeah. So Sue, yeah, if you want to unmute yourself, I'm happy to answer your question. Or you can write it in the Q&A. Okay, well, maybe we'll get to the end. But in any case, there were these headlines, and I reviewed the story. I looked into this, and really, this is it's important to look into these things. I'm not saying this isn't. It's always important to uncover the truth, and if there's scientific fraud, appropriate actions need to be taken. We need to reevaluate what's going on. I think that's very important. But really, this relates to very specific publications by one person on a very specific type of amyloid. As I mentioned, there are so many types of amyloid, and this was on the subtype of amyloid oligomer called A beta 56 that this one person had discovered. And apparently there were some figures in the papers that seemed manipulated, and so on and so forth. And the reason why this paper was important was it was one of the first paper that pushed us, towards the left direction, that these sort of more soluble forms of amyloid are also important. But honestly, it didn't really have the type of impact that these headlines thought it did. I mean, sure, it's a highly cited paper, but we know that the amyloid theory is held up by so many other studies, and which is the frustrating part of this field. The presence of amyloid is necessary for development of Alzheimer's type tau and subsequent neurodegeneration and decline. We know that the genes for Alzheimer's disease are in the amyloid production pathway. Putting these genes in mice makes them have amyloid, and reducing amyloid seems to have a little bit of impact on decline. So it may not be the only theory, but it certainly is a theory. And even the soluble amyloid that this person was researching, there have been other forms of soluble amyloid that have certainly been studied and validated and independent of that. So I feel like it was a grab for headlines, although it was based in some truth. So it's a good lesson to be careful what we read in the news. So I'll stop there, and I'm happy to take questions. And then there's some in the question and answer. So